All right, everybody, I think we'll go ahead and get started with our afternoon session. Welcome back from lunch. And there's just one announcement that I wanted to make. We added a new workshop for tomorrow for hands-on physical exam, essential shoulder, and it'll be at 4 p.m. So if anybody's interested, you can feel free to sign up through the app. Okay, and then I will introduce our speakers for our first afternoon session. The session is going to be on management of acute low back pain in kids and adults, cases from clinic. So first, I will introduce Dr. Paulo Membella. He's a double board certified interventional pain physician in the UCSF Department of Orthopaedic Surgery, and he works in our UCSF Spine Center, and he specializes in interventional pain medicine and rehabilitation to treat different spine conditions. His clinical expertise encompasses a wide range of interventional pain management techniques. His research interests are centered on regenerative therapies and minimally invasive interventions, including injections, nerve blocks, and ablations, with the potential to benefit patients with both chronic and acute problems of the spine, spasticity, and also osteoarthritis. He serves as the medical program director for the UCSF Interventional Spine and Musculoskeletal Medicine Fellowship, and his educational background began with both a bachelor's and a master's of science in exercise physiology from the University of Miami, where he graduated with honors. He subsequently earned his Doctor of Medicine from St. George University, Granada. He then completed his residency training in physical medicine and rehabilitation at the University of Texas at Houston McGovern School of Medicine. This was followed by further specialized training as he completed a fellowship in multidisciplinary pain medicine at Montefiore Medical Center, affiliated with the Albert Einstein College of Medicine in New York. And fun fact, he's also a lifetime sports and fitness enthusiast. He still participates in jiu-jitsu, and in a former life, he was a strength and conditioning coach. And he's happy to talk to any of you about some of those things that you might have in common. So please join me in welcoming Dr. Membella.
Thanks, everyone.
And the other speaker I'm going to introduce is Dr. Selena de Borja. So Dr. Selena de Borja is a pediatrician with special training in sports medicine who cares for children and young adults with a wide variety of musculoskeletal conditions. In addition to general pediatric orthopedics, her areas include sports medicine and dance medicine, injury prevention, and bone health. She's originally from the Philippines, and she earned her medical degree from the University of the East. She completed her pediatric residency through Hackensack Meridian Health at Jersey Shore University Medical Center, then completed a fellowship in sports medicine through Harvard Medical School at Boston Children's Hospital. Dr. de Borja is the director of the UCSF Play Safe program and is the team physician for Balboa High School in San Francisco. She also serves as the medical director of the ODC Healthy Dancers Clinic, wherein she collaborates with other healthcare professionals to provide educational programs, musculoskeletal screening, and to care for dancers and performing artists. She's also a member of our new UCSF Women's Sports Medicine Center. I have the honor of working with her every week, every Tuesday at the UCSF clinic in Redwood City, and she also sees patients in San Francisco. And fun fact for Selena, her Spotify year-end recap said that her listening age is 28 because she is a millennial stuck in the 90s and the early 2000s. So the opposite of Dr. Hadamiya here. It also said that she listens to so many genres it cannot define her taste in music. And we think it's because her toddler daughter might have taken her phone. So please join me in welcoming Dr. Selena de Borja.
Thank you, Dr. LaRoque. So good afternoon, everyone. Thank you for joining us in this session for back pain. As mentioned, there's going to be two presentations for this session. I will be presenting on the pediatric cases, while Dr. Membella will be presenting on the adult cases from clinic. So no relevant disclosures for this talk. So the main objectives of this talk are to discuss the general principles for caring for children or adolescents who present with back pain, to identify common causes of back pain, and apply diagnostic indications as well as treatment modalities, and also to recognize features that should prompt referrals to specialists. So As mentioned earlier, I work in the pediatric orthopedic clinic, so I do see a fair amount of athletes, but I also see kids who are not athletes, just kind of play childhood activities or don't engage in physical activity at all. So for me, my differential for pediatric back pain is pretty broad. Especially for those who practice in primary care, pediatric back pain could be considered a box of chocolates, as Forrest Gump once mentioned. It could be, you never know what you're gonna get, right? So I think, for us who work in orthopedics, sometimes we kind of narrow it down to musculoskeletal or mechanical reasons. However, I think it's very important to remember that pediatric back pain can also be from systemic etiology. So there's infectious reasons, inflammatory, neoplastic, hematologic, or congenital conditions that may present with back pain. And I think it's just really important to think about those things as well to make sure that we're referring our patients to the right specialist if needed. And so as I've trained in medicine and also pediatrics and sports medicine, I've always found it relevant to have good history, especially in a case where there's a broad differential. And so as I teach all our trainees, the history really will give you about 95% of your differentials. Your physical exam may confirm some suspicion, and then your diagnostic imaging can help as well, but history is really important. So I always try to get information in a very organized manner. So asking about duration, is this acute or chronic? Was it sudden onset or insidious in onset? Was there preceding trauma or injury prior to the onset of symptoms? The back is a pretty big structure. There's a lot of different locations where someone can have back pain. So I'm very specific when I ask kids where their pain is. Is it upper, middle, or lower back? Is it really lower back or by the tailbone? Is it midline or more to the sides or their paraspinal region? And does it radiate to any extremities? I also try to ask the character of their pain, try to have them describe it in their own words. Is it sharp stabbing, dull, achy? Is it feel tight, squeezing, just uncomfortable, kind of nagging pain? I try to ask them to rate it on a scale of 1 to 10, which we all know could be subjective, but it sometimes could be helpful information as well. I ask about the timing. Is this intermittent or does it come and go? Is it persistent or always there? Does it come in cycles depending on certain activities or times of the month, things like that? Is it more prominent in the morning, in the evening, before or after participating in sports or movement? In addition, some aggravating and alleviating factors also are helpful. And so certain types of back pain are more painful with forward bend or spine extension or lateral rotation. We'll talk a little bit about some common cases I see in the clinic in the setting of sports. If they are an athlete, I try to ask them, what type of sports they play, at what level, how many hours they're playing these specific sports per week, especially when we're thinking of like overuse injuries. And then if not, I also try to ask about ADLs, lifestyle, are they pretty sedentary? Do they like walking? Is there anything they want to do as a family? It may also help me when trying to, give some lifestyle recommendations. So say they're not on the athletic side, try to give the family something to do together to be more active, I think is kind of how it's also helpful. Over the past few years during the COVID pandemic, all our kids were studying at home. And so at that time, I saw a lot of pediatric back pain related to their study habits. And so kids were just kind of doing Zoom classes from their beds. That's not necessarily ergonomic. And, they're taking classes for hours a day, and everyone just had back pain. Alleviating factors, also very important detail to ask. Chronic back pain, whether it's like weeks, months, or years, if it's self-limiting or alleviated by very conservative measures, not so concerning. However, if someone says that, I've only had back pain for a few days, but I've already taken medicine, they're maxed out on their over-the-counter dose, or they've tried all these interventions already, and it still persists, and then that might be more concerning for me. As I mentioned earlier, systemic etiology is also, could cause back pain. So thorough review of systems would be helpful. And this is, why I think, working with our primary care colleagues is really important because you know the patient best as you're their primary home. Asking about past medical, surgical, family medication history could also be relevant because I'll present some red flags later that might be helpful in kind of pointing to our differentials. And so for physical exam, kind of similar to how we learn to perform these things, I always try to teach them in a stepwise approach. I know we have sessions on actually performing physical exam and hands-on demonstration during this course. So if you have any questions, please feel free to kind of approach us about certain maneuvers. But we always start with inspection, and that starts with the way the patient comes walking into the hallway towards their exam room, how they're sitting on the exam table. Some might be in severe pain that they're, you walk into the room, they're automatically like lying on the table because they're so uncomfortable. Looking at their gait, posture, symmetry, looking for any midline cutaneous lesions that may be associated with neurospinal conditions. And then I proceed with palpation. So us in orthopedics or MSK medicine, we're very location specific. So I try to palpate the vertebrospinous processes by the midline, as well as the paraspinal muscles and the SI joints, trying to see like where exactly the pain is. And then we can move forward to some motion testing. For forward bend, you have the patient bend forward. There's a few pieces of information that you can get from that. One is, does it hurt to bend forward? Number two, what's their kind of flexibility like? It is very common for teenage boys to have poor hamstring flexibility and not be able to touch their toes. But, if they can barely, reach kind of their knee or shin level, then definitely very tight. At the same time, since you're already kind of looking from the back and having them bend forward, my kind of lens as someone who works in pediatric orthopedics also look at spine alignment or asymmetry. So I also kind of capture the Adams forward bend test during that exam to see if there's any suspicion for spine deformity. And then in addition to forward bend, we have them arch backwards or extend their spine, bend both sides and rotate both sides. And then for more kind of specific suspicion for maybe a stress injury or like spondylolysis, we also do the Stork test or hyperextension. Any spine exam should always be paired with a neurologic exam. In a situation where maybe you may be thinking of any systemic etiology like infectious, vital signs would always be helpful, as well as anthropometric. So if there's maybe some concern for a neoplastic or malignancy situation, then if there's any unintended weight loss or things like that, then that might be helpful. Obviously, testing other organ systems is indicated. Again, the back is such a big structure. If there's any need for doing a respiratory or like abdomen exam because you're thinking it's just kind of it's like organ system pain that's kind of radiated to the back, then that might be helpful. And then other provocative maneuvers that we perform for kind of the MSK reasons for back pain would include your straight leg raise or the slump test, which is on the photo on the right side, as well as the Faber test, which we kind of learned from our rheumatology colleagues, help kind of elicit any pain in the SI joints. And so after gathering your thorough history and physical exam, here are just some red flags that could help point towards specific differential diagnoses that could help you decide, need for diagnostic or blood test, diagnostic imaging or blood test, or referral to certain specialists. So any abnormal neurologic findings, we think space occupying lesion, is there a spinal epidural abscess, cord tumor, nerve root compression. If there's a repetitive trauma, especially in kids who do a lot of spine hyperextension like gymnastics, we think of spondylolysis. If there's pain that radiates below the buttocks, so kind of like sciatica type pain, you may think of discogenic etiology. If pain is persistent, nocturnal, severe pain, wakes them up from sleep, those are typically some red flags or buzzwords that we use for systemic etiology like inflammatory, infectious, or even neoplastic cases. And then same way, any fever, systemic signs, plus back pain, think infection or neoplasm, morning stiffness. And so, I learned from our rheumatology colleagues, they always say, if pain happens after activity is improved with rest, then usually it's mechanical or musculoskeletal. If pain is there before you even do anything, so after rest and maybe gets better with a little bit of movement, then you might think inflammatory. That's kind of where morning stiffness might be helpful. Anyone with a history of malignancy, think of any metastases to the spine. For those who may be seeing patients who've traveled, especially to areas where there's exposure to certain infections like tuberculosis, Pott's disease is also a differential for back pain. And then pain in really, really young kids, so 4 years old or less. Definitely, we take that very seriously. And so when someone's coming to meet a clinic, really young child having back pain, so we definitely do a full workup on them, blood test plus imaging. And so this is an algorithm that I got from an article published in 2020 by the American Family Physician Journal. It's going to be in your syllabus. And I'll kind of go through the algorithm as I go through some of the cases. But yeah, just on the left side, it shows someone who's presenting with back pain of less than 4 weeks, no red flags. You can go ahead and treat them conservatively, whether it's at-home exercise program, over-the-counter medication, or even sending them to physical therapy. That's a completely valid approach. On the right side, anyone who's had pain for longer than a month, especially if there's red flags, and there's some recommendations on diagnostic imaging and other lab tests that could be gathered and then kind of treated accordingly. And so I'll go through some of the common tests that we'd recommend for someone presenting with back pain, kind of show also what you may see with these tests or what you may expect. So for radiographs, common indication would be, again, any concern in physical exam, radicular pain, persistent nighttime pain, constant pain, or pain for more than a month. It may reveal any malalignment, so scoliosis or kyphosis, which we do see in our adolescent population. It may reveal bone injury like spondylolysis or vertebral fracture if there was high-velocity trauma. If the pain's been chronic enough, it might show changes relevant to someone who's had discitis or osteomyelitis, or it may show any findings that are kind of out of the ordinary, like bone lesions or tumors. MRI is recommended if there's any abnormalities in your physical exam, especially your neurologic exam. It is recommended for those cases where there's high index suspicion for infection. So as I mentioned earlier, if you get the X-ray and the symptoms have been long enough, you might see changes on X-rays. However, if it's still pretty early, you might not see any changes in X-rays, and the MRI might be helpful. And then, any abnormalities in the spinal cord, spondies, disc issues, inflammatory findings you can also see on an MRI. Also important to know, like I mentioned earlier, systemic etiology is part of the differential for back pain. And so I think a lot of our patients always look for imaging. We get X-rays. We may or may not see something. They always want to jump to an MRI, especially if the X-ray doesn't show anything. But I think it's also important to educate them about the role for kind of laboratory diagnostic studies. And so, typically basic labs include your CBC, ESR, and CRP. And then there's additional labs that could be helpful depending on what you're looking for. So again, I think have your differential, have a clinical suspicion, and then you can kind of get labs that would maybe confirm your suspicion. For neoplastic cases, you may consider adding in LDH uric acid, inflammatory. You can get some of those ANA or HLA-B27 markers. And then if you think this is an extraspinal situation, for example, like pyelonephritis might present with lower back pain, then obviously testing other organ systems as indicated. And so now we kind of move forward to just some information about pediatric back pain, and Dr. Membel will talk about the adult counterparts. So the data on pediatric back pain is somewhat all over the place. As you can see, studies may say pediatric back pain can be seen in 4 to 74% of cases, and they vary by country and period. So it's really all over the place. Like, is it common or is it rare for children to have back pain? A more recent study done in 2020 in the United States showed there's about 33% of children aged from 10 to 18 who reported back pain. We do see back pain increases with age. We do see it more in girls compared to boys. We do see it in kids who have family history of back pain in adults, or those who've reported some form of injury to their back. And then just historically, and even kind of the way I learned about it is, people who report back pain as children or adolescents may be adults who have back pain in the future. But one thing that I also kind of gathered in all these articles that I've seen on back pain is, there's one thing such as level of activity that could be modifiable in back pain. So as you can see on the graph on the right side, back pain follows a U-shaped distribution, wherein, yes, too much activity can cause back pain, but also lack of activity could be associated with back pain. So I tell kids or families, like, finding happy medium in terms of physical activity, might be helpful in making your back happy or quiet. And so the first case is kind of one of the more, benign cases of back pain, but, most common case of back pain that we see in our pediatric clinic. It's also known as, nonspecific low back pain. They're also known as hyperlordotic, mechanical, muscular, or idiopathic back pain. Basically, kid has low back pain. There's no specific, finding maybe on, physical exam or even on, like an X-ray, or, no specific pattern. There's just back pain. But ultimately, we do know that these are usually kids who will have a tight posterior chain due to rapid growth, which will lead to increased lumbar lordosis. So they'll have tightness in their hamstrings usually, which puts a lot of kind of load in their lower back. And so these are the ones that we see a lot and would definitely encourage physical therapy or exercise-based interventions, typically to target any weakness in their core, or if they're very athletic and they have strong core, I usually try to educate them that you don't only need strong core, but you want to engage your core so that it supports your back, and to work on the kind of parapelvic or hip region as well, because they're all related. And so as mentioned, we recommend activity modifications. And so that's where kind of, finding the happy medium of physical activity would be helpful. Ultimately, encourage physical activities. So, even if they say, if I do exercise, it hurts, for me, it's really finding something that maybe their back is not kind of sensitive to. So if it's not running, it's walking, maybe biking, maybe swimming. And then really maintaining that stretching and core strengthening program at home. Second type of back pain that we see in our clinics is specific to young athletes. So spondylolysis, it really is just 5% of the general population, so it's not so common, but in a study that was done specifically in a pediatric sports medicine clinic, they saw that 47% of cases of the young athletes presented to that sports clinic for back pain were from spondylolysis. So if you're seeing just kind of like regular kids, then maybe not so high in your differential, but if you're seeing someone who's really having high hours in the gym or practice or competition, especially if they're engaging in sports that involve a lot of back arching, then you can think about spondylolysis. In contrast to adults, where we see a lot of discogenic etiology back pain, we don't see them as much in adolescents, only 11% compared to 48% in adults. But not so common, but nevertheless, we still see them anyways. But just to kind of like show kind of difference in case that you might see in a pediatric patient who's presenting back pain. And so spondylolysis and listhesis are injuries to the posterior elements of the spine. Spondylolysis is an injury to the pars interarticularis, and listhesis is if you have bilateral pars injuries that leads to forward translation of the segment above it over the one underneath it. So typically they're stress injuries, meaning we see them as like chronic, kind of progressive type back pain, especially in high volume sports. But sometimes we also see some acute injuries, especially with like trampolines, or someone says, I was doing a lot of sports and then something happened and then kind of hurt my back. Again, we see them in young athletes because the growing spine is susceptible to repetitive hyperextension, rotational loads. We see them in gymnasts, ballet dancers, divers, as well as other sports where there's a lot of arching or twisting of the spine, maybe from throwing, so like lacrosse, baseball, or football. On physical exam, these kids usually will have increased lumbar lordosis and hamstring tightness, which is very similar to the other case of back pain that I presented. But these kids specifically will have some tenderness down the lumbosacral region, midline of the spine, because there's a pars injury. And then their pain is provoked by hyperextension, so single leg hyperextension or Stork test, which we use in a sports clinic. Basic workup for spondylolysis includes radiographs. Typically, AP and lateral views are enough for these conditions. Historically, and as I took my board exam a few decades ago now, they do mention the oblique views for spondylolysis. I think there's more recent studies that say that it hasn't really increased the sensitivity of the x-rays to the spondies, and so they didn't think that this higher radiation exposure to that area would be worthwhile. So kind of more recent suggestions show that if you have high suspicion for spondylolysis, your lateral view x-ray is negative, you may want to just get an MRI to kind of confirm that diagnosis. Diagnosis is more sensitive, and through the MRI, it can detect the stress reaction phase, so meaning there's no like actual crack or significant gap yet in the pars that would show up on x-ray. It would show up on an MRI as bone edema. And then CAT scan, sometimes we use not kind of in the acute setting, but more kind of down the line when we try to assess healing or determine like an injury's chronicity. Treatment for spondylolysis is a little controversial, but I think the bottom line is it does take time for these injuries to heal. And it's really difficult because a lot of these are seen in athletes, and their seasons are usually like 12 weeks long. And if you have an injury that may heal in like 12 or maybe more weeks, like 4 to 6 months, then this could be something that interferes with their sporting season. Some protocols in the literature support bracing for spondylolysis, while others don't necessarily believe in bracing. I think it really just depends on where you train and kind of what the thought process is in your institution. Where I trained in Boston, as well as where my partners in pediatric spine surgery trained all over the country, we do recommend bracing, which is usually the anti-lordosis brace. However, if you find someone who's been seen by a specialist and didn't brace, it's not necessarily wrong. It does exist, just to let you guys know. Or if there's any barriers to obtaining a brace, for any reason, it is still an acceptable way to treat it without a brace, I think is what I'm trying to share as well. For us, especially, I train in pediatric sports, we do believe in it specifically because there are studies out there that showed faster return to sports in the brace group compared to the no brace group. But again, if there's any reason for them not to be able to get their brace, then that's acceptable as well. With or without the brace, intensive physical therapy is part of their protocol. So, making sure we correct any issues on hamstring lack of flexibility or core engagement, and making sure they have better biomechanics when they return to their sport, especially if it requires a lot of axial loading. And the goal of treatment for these conditions is to prevent progression because especially during the growth phase, some cases of bilateral stress fractures can lead to listhesis or the slippage. And so in adolescence, we try to kind of treat them a little bit more proactively for those reasons. For those who failed on operative treatment or have what we would consider unstable spondylolisthesis, wherein the slippage is more than 50% of the width of the vertebral body, then those would be indications for surgery. So that's when I would send to my partners for intervention. Okay, last case before we move on to adult cases would be discogenic back pain. This is described, or this reflects low back pain from a portion of a disc that kind of pushes back, which may irritate the nerve roots or the existing nerves. In pediatrics, we do see this, so this is not just kind of an adult condition. We do see it. The data earlier says about 11% of kids with back pain may be discogenic. I think more recently, since it's easier to get MRI just in general compared to decades ago, I think we're just kind of seeing them more earlier too. And so I think that's kind of how I explain it to families, especially when they're really worried, why does my 14-year-old already have like some disc findings? So yeah, there could be genetic factors as well as environmental factors that could, cause discogenic back pain. And we also see them in activities where there's a lot of collision for sports or weightlifting. So typically, this is a back pain that's worse with flexion. They may present with some radiculopathy, and they may have a positive straight leg or slump test that reflects sciatica. So the way to diagnose, X-rays could still be your first line of diagnostic imaging. Yes, you do not see the disc on an X-ray, but you could see any slippage or disc space narrowing that might reveal maybe a more advanced form of discogenic low back pain. MRI does confirm the clinical diagnosis of a herniated disc. In children especially, we treat this very conservatively. It may take 6 weeks or even more. It's just kind of one of those injuries that our kids have to be patient with. And typically it's a period of relative rest, but we also don't want them bedridden or avoiding physical activity for too long, because that's also not helpful for these cases. Definitely physical therapy. Most of our patients, we see discogenic back pain, never go beyond physical therapy. Typically physical therapy, when done appropriately, is very effective. NSAIDs can help reduce pain. And then for those very rare cases where physical therapy is not helping, or maybe they're just in so much severe pain that they couldn't even do their physical therapy exercises, then some selective injections could be recommended. And then, ultimately I tell them, these selective injections, aren't necessarily cure for these conditions. They're just ways to help you, decrease your pain a little bit so that you can do your physical therapy more effectively. So kind of going back again to the intervention of physical therapy. And then lastly, there is, some surgical indication in this condition. So for those who've definitely failed conservative treatment, or if there's any concerns about how much narrowing there is in the neuroforaminal space, we'll send them to neurosurgery colleagues for a consult. All right, so before we move on to the adult part of the session, just wanted to reiterate pediatric back pain has a wide differential diagnosis. History and physical are very important. Watch out for red flags. If you're going to do a workup, try to have an idea of what you're looking for, because again, you never know what you're going to get. And then level of physical activity is a modifiable risk factor for back pain. So thank you, everyone. I think we'll just receive questions after Dr. Mambella's talk.
All right. Thank you, Selena. That was very detailed. I think you'll all notice that a lot of the principles that Selena was talking about are going to apply also in the adult realm. I'm going to focus primarily, I want to highlight two words, adult and acute, because that's what my talk is really going to be focused on. There's obviously chronic low back pain, or acute that then becomes subacute, transitioning to chronic low back pain. If you all are interested, I do highly suggest you stick around for the next talk. After this, my partner from work, Dr. Patricia Zhang, who's in the back there shaking her head, will be giving her talk on chronic low back pain. Before I get started, I wanted to ask one question. I know that our audience is composed of athletic trainers, physical therapists, general practitioners, APPs, so PAs, NPs. Did I miss anyone? Is there anyone out here? Because I want to make sure that I tailor this as much as possible to the audience. Yes? Medical student. Okay, so you can go many directions. Anyone else? Okay, so, yeah. Urgent care ER. Okay, perfect. Definitely we'll be talking about our roles together. Which button is it? This one. Thank you. All right, I have nothing to disclose. I'll try to move through this a little bit quickly because I want to make sure to give everybody a chance to ask questions at the end. These are some suggested readings. The Bruckner and Kahn text is foundational in sports medicine. The Bogduk text, Dr. Bogduk is considered one of the godfathers in the interventional spine world. And the Physical Medicine Rehabilitation Principles text, edited in chief by Walter Frontera, is one of the foundational books in physiatry itself. If anybody's interested, I did interview him in a podcast I ran when I was in residency. You can just give that a quick Google. So our goal today is to provide a bit of a foundation so that you can create your own algorithm, decreasing unnecessary imaging, improving hopefully safety, and streamlining referrals. I really want to give you all the tools to more quickly and effectively take care of this patient population. I do strongly feel that algorithms are just tools. They're not the end-all be-all, so I want to make sure that we don't get stuck purely thinking in an algorithmic way, but don't ignore the algorithms as a tool in your toolbox. So why is this particular issue challenging? Depending on who you read, you'll see different statistics ranging from 50% of all adults are going to experience back pain to 100% of all adults are going to experience back pain. I don't know about you all, but I've experienced back pain even in my early 30s. So I think it's a fairly ubiquitous, I'm not in my early 30s anymore, I meant when I was in my early 30s. It's a fairly ubiquitous experience. And some of the issue when you're reading the literature is what's defined as experience. I mean, are they saying, hey, you had 1 minute of back pain, a year of back pain that then causes disability, or that causes you to end up seeking some kind of urgent or emergent medical care? Particular questions that I've asked around in the past to my colleagues in your positions is, where do we get stuck? So these are the questions that I was given back. When do I image? What image do I use? Is an X-ray okay? Is an MRI okay? Advanced imaging, when is it necessary? Which cases should worry me? You'll hear this term red flags over and over again. How long do I have to wait before I have to refer to a specialist that works in spine? And then which treatments actually help in the acute early, week 1 to 6 phase? So we'll try a few cases and hopefully this can help drive those points home. So case 1 is a gym enthusiast with acute pain. This is a 32-year-old active right-hand dominant male, computer science engineer. He comes into your office with acute, started out of nowhere, sharp right-sided lower back pain. He mentioned that he was deadlifting a week ago and noticed either a pop or something happened back there, and then the pain started. When you examine him, there's mild tenderness in the lower back with palpation. Manual muscle testing is 5 out of 5 in all myotomes of the lower limbs. Sensations fully intact. There are no red flags. Deep tendon reflexes equal and bilateral in the knees and the ankle. Pain is worse with extension. Pain's about an 8 out of 10, but rest improves it. So this should get your diagnostic juices kind of flowing as to what's happening here. Is this an acute thing? Is this a chronic thing? Do I need to send this person for advanced imaging? What are we thinking? And so key teaching points of this particular, your top 2 differentials are acute paraspinal strain and facet irritation, so some kind of issue in the facet joints. This is primarily given to you in the history and your physical exam when the patient's telling you that if I extend, that's really when things get worse. No imaging is necessarily recommended in this case. I mean, we saw there's no red flags. It is early on. You can consider, so I've had other physicians, general practitioners, urgent care physicians ask me, you know, what should I do if this is brand new, but the patient is very concerned? Well, reassurance is part of your treatment as well. And you can always bring them back at a short interval. So that way the patient doesn't feel like you're just saying, it's nothing, you know, come back if it continues to be a problem. Give them a comeback date. So come back in about 3 weeks, 4 weeks, 5 weeks, 6 weeks. Use those short intervals. That's going to help you. And then you can reassess the patient. Are they actually doing better if they come back at a short interval? Don't prescribe bed rest. It's in PM&R, it's a big no-no. We try to get patients up and moving as much as possible. This was an old thing. I think we used to prescribe bed rest as physicians about 100 years ago. It's not the current meta in medicine. Actually, an interesting take is that there are a few physicians out there working in ICUs, getting patients who are even intubated, very sick in the ICU up and moving while they're still hooked up to ventilators and showing that this decreases morbidity and mortality. So first line plan, NSAIDs or Tylenol are okay, as long as there's no contraindications. Heat, gentle mobility. I'll actually disagree with the heat in the acute phase. I tend to think that cryotherapy or ice helps better in the acute phase, but some patients prefer heat. So just ask them to try and see what feels better for them. I recommend PT early. Then once we get our physical therapist, physical therapy assistants, ATCs involved, they can gently work with the patient early on, gentle mobility, and then progress as the patient tolerates. Usually this helps get them back on their feet into unrestricted movement quicker. You want to avoid opioids, especially in the early onset for these particular issues. And then return to sport is a functional progression. That could be a lecture in and of itself. So the Pearl for this one, pain with extension. Think facet, pain with flexion, think disc. I think the example is not great because it happens when he flexes as a late, great Rodney Dangerfield there. Kind of aging myself. See, I'm not 31. So case 2. So now we have a 47-year-old right-hand dominant female. She's a business executive. She was hiking 2 weeks ago, and afterwards she noticed new leg pain in the left side radiating all the way down to the foot. On exam, you notice positive straight leg raise on the left. She cannot sit, but she ambulates fine. Red flag screen is negative. Sensation is altered in the left leg in the L3, L4, and L5 dermatomes. There is no bowel or bladder incontinence. Pain is 5 out of 10 at baseline, but if she sits prolonged, she tells you that it can flare up to 7 out of 10. So I don't mean to insult anybody's intelligence here. I mean, it's kind of in the top of the slide there, but we're thinking acute radiculopathy. Now you're having referred pain patterns. So are we going to put them on opioids? Are we going to prescribe bed rest? Here's the teaching points. A little bit of a busy slide, but radiculopathy does not automatically mean that you need to send the patient for advanced imaging, is really what I'm trying to get across here. Again, you want to use those short intervals to your advantage if you're concerned and you think, you know what, my gut tells me this is not necessarily going to resolve in 2 months. So I'll just bring the patient back in 2 weeks, 3 weeks, see how they're doing. Are they doing any better with activity modification, with maybe, again, NSAIDs or a short course of steroids? You can consider steroids if there is a radiculopathy present. If radiculopathy is not present, typically we don't recommend steroids. You have to take the patient's full history into account here. If there's some kind of rheumatologic condition, well, you probably want to reach out to the primary care physician, potentially even the rheumatologist. So 80% of these can still improve without intervention, without injection, without surgery. So again, you don't want to jump the gun too quickly in sending them for injections. Not everybody is going to need them in these cases. I tend to think of this pathology as an inverted funnel, where the reason it's a funnel is because it's really wide at the top and really narrow at the bottom. And as you progress downward in severity, so most patients, most of us that have some kind of back issue, we might not even go and see a medical professional at all. And it will just kind of resolve on its own. then a smaller subset of that back pain population actually seeks, maybe urgent care. Maybe they talk to their PCP. Maybe they're in physical therapy for a completely different reason, and they ask their physical therapist, hey, you know what? My back kind of bugs me here. So they do get some kind of professional intervention. And then a smaller subset needs multidisciplinary care from physical therapists or PCP, maybe a spine specialist, and so on and so forth. So I think you get the point. So as that back pain becomes more and more severe, more and more chronic, then you probably need, further subspecialist care and potentially, at the bottom of that funnel, potentially even surgical care. So as I mentioned, I think a little bit earlier, reassurance is part of your treatment. So patients need to hear that from you. So Pearl, of this case, is positive straight leg raise, does point to disc irritation. The slump test is even more sensitive. The slump test basically being a straight leg raise with Brzezinski's tied into it, where you put a little bit more tension on that spine by flexing the cervical spine forward. And then the final case that we have, and again, I want to make sure I don't run out of time here, give you all a chance to ask questions, is an older adult. So 68-year-old female playing with her 2-year-old grandson in the park. This is a patient of mine. She slid down a slide, landed on her bottom, felt immediate sharp pain in her lower back. She has difficulty with bending and extending. So now the last two principles, they don't fit perfectly to the other two. She tells you that bumpy car rides really aggravate her back. She has no bowel or bladder incontinence. Lower limb strength is equal and intact. DTRs are also within normal limits. She's ambulating slowly, but she's not using any gait aids, no cane, no walker, anything like that. Pain at rest is 2 out of 10, but it worsens with percussion testing. So the whole point of this slide is to highlight a few things. In your older population, especially when it's acute, again, we were talking about acute presentations, you want to make sure that high in your differential is vertebral fracture. So always consider vertebral fracture in any patient over 60 years old. If point tenderness, if you notice point tenderness on your exam, you definitely want to get at the very least an x-ray. My opinion here, and it's just my opinion, I do think that in these cases where you have a pretty strong suspicion of a fracture, you can just bypass the x-rays, go straight to an MRI. With your MRIs, a little bit of a pearl for everyone out there, you want to make sure you get your STIR sequences. So it's a particular subsequence of your MRI that highlights where there's bony edema. Management initially is to avoid prolonged rest. Selena was talking about bracing, especially in the adult population. I don't know how it is in the pediatric population, but adherence is very low. But it should be part of your treatment algorithm. It can help prevent progression of these fractures. Tylenol, NSAIDs refer if pain is severe and fracture is present. I think the patient bought themselves a referral to a spine department. Consider a short course of opioids or pain management strategies. Here you actually want to consider that depending on pain levels. Maybe you start with anti-inflammatories, Tylenol, but these patients tend to be even more severe pain. They tend to also have other underlying etiologies, so you want to make sure that you're managing those symptoms. When to immediately refer persistent disabling pain, the patients in your clinic, you have a high suspicion for this fracture, pain's 10 out of 10, they literally can't do anything, immediately refer them. Stooped posture, or if they're developing worsening kyphosis, these fractures tend to occur mostly in the anterior portion, and so they wedge forward. And this can become a permanent disabling and worsen morbidity as well. Something as simple as lung function can decrease if this goes untreated. So these are the patients you want to urgently get in for referral. Loss of function or neurological change, of course, in any case, if you've got red flags or you have, neurological change, you want to get them in for a quick referral. And then, of course, if they fail conservative measures and you're trying your best, they're just not getting better, refer them out. So what not to do in every case of acute onset low back pain. I think we've already gone over this as we were talking about the cases, but you don't have to order routine MRIs, CTs on everybody. You don't have to give everybody opioids. As a matter of fact, outcomes tend to be a little bit better if you don't start those in most acute back pain in adults. Avoiding muscle relaxers, this is plus or minus. You do want to let your patients know if they have high-risk jobs requiring a lot of coordination, that all muscle relaxers are going to affect their cognition. So be careful with those. No strict bed rest, we talked about that. Sometimes in my clinic, patients are asking me, well, what's the best mattress? What's the best chair? What's the best ergonomic? There are some general principles. Most of us tend to have two lower limbs and, we're bipedal hominid. So there is some overlap, but height's different, weight's different, Q angles in the pelvis are different. So much is different that there's no one universal best chair for everyone, one universal best mattress for everyone. So kind of help your patients not over-focus on these things. And then also careful with pathologizing normal or expected MRI findings, especially if you have, someone who's north of 30 years old. I've told my patients before, you start to see degenerative changes in humans in the lumbar spine in particular pretty early on. This is not meant to poke fun at our ER doc colleagues. Some of my absolute best friends in emergency medicine are ER doctors. It's just a funny meme, but the point is just that. Don't skip your history, don't skip your physical exam. There's an old saying in medicine and medical school, and that's 90% of your diagnosis comes from your history, and maybe 8 or 9% from your physical exam. 1% comes from your advanced imaging. Those things should support what it is that you're looking for, what it is that you're trying to diagnose, not necessarily, well, you have back pain, everybody MRI. Imaging indications, so I think we already went over this. I X'd out that word progressive for a specific reason. If a patient has motor deficit, in my opinion, you should probably refer out to a specialist. Suspected fracture, suspected infection or malignancy, so these are some more of your red flags. Or if symptoms or radiculopathy is present for more than 6 weeks, the patient's just not getting better even with a short interval, you probably want to get them in. If you're considering, you're managing from top to bottom and you're considering, I think this is a good patient for some kind of nerve block or epidural or something like that, I do suggest that you get advanced imaging because that is a requirement preoperatively for even the injections. So a few rapid assessment tools. Again, I don't want to run out of time, so I'm going to move through this quickly. I'll leave that up there for a second for anyone that wants to take a picture, but most of this I think we talked about. Injections, when are they appropriate? Not for acute strains, definitely. Epidural steroid injections are really only for radiculopathy. That's failed conservative therapy. Facet joint injections are very rarely in the acute phase. That's more of a chronic treatment. It's more for degenerative zygapophyseal joint mediated pain. And trigger point injections, occasionally for severe spasms, but make sure that, a patient's not relying on these injections. It's just to help kind of calm down the pain and then get them moving. That's what's going to give them long-term improvements. Just a couple of pictures on the left side of your screen, trigger point injections. Top right would be a transforaminal epidural, and then bottom right is a cartoon of a medial branch block. Case-based summary, I think we went over case 1, 2, and 3, and we talked about really this is just driving home exactly what we talked about. Practical takeaways, so most acute back pain improves with conservative management. Remember that inverted funnel we talked about a second ago. Imaging is not needed in every case. Stay active early, no bed rest, try to avoid opioid medications. Reassurance is part of the treatment. And then refer early for red flags or if there's neurodeficits. And then when in doubt, just refer out. If something's not fitting any kind of algorithm perfectly, that's what we're here for. We're here to work together. I think we already went over this. And a few take-home points. I'll leave that slide for about 10 seconds. I can see that we're running low on time. And then here are my references. Thanks, everyone.
Okay, so I think we have time probably for about 2 questions. There are actually 2 in the Q&A, one for more Selena.
Okay.
Selena, come back.
Sure, yeah.
And then one for Paulo. Okay, so Selena, I would like to know the answer to this too, as I have kids who both use backpacks, but what can we advise parents and kids regarding the use of backpacks?
Yeah, that's like a decades-long problem. When I was young, that was already a problem, even now. And I'm actually surprised now that things are digital. I thought that, they'd have less in their backpacks, but heaviness in backpack is associated with back pain, has been kind of, related to back pain. And so I think if possible, especially if there's like school resources for like lockers and things like that, or if there's maybe classes that aren't happening on a daily basis, kind of like changing out the contents of the backpack to try to lighten it up a little bit. I guess wearing your backpack properly as well is something we talk about. The kids' backpacks I heard nowadays is 50 pounds heavy, and if you're kind of only carrying it on one side versus the other, or maybe carrying it low, meaning you're kind of increasing your lumbar lordosis, that might be associated with back pain. So maybe carrying it properly might be helpful. But yeah, it's something that is still a challenge for us in pediatrics, and it's really trying to see kind of what would work for the family. Because and it also a lot of parents will say, can you do a rolly backpack, and no kid ever wants to do that, right? And even if they were amenable to it, not all schools have facilities for rolly backpacks anyways. So it's really just kind of seeing what'll work. But it's been a challenge for sure.
And to backpack onto the backpack question, case 2 that I had, the hiker, we didn't go into it. I didn't want to go down that rabbit hole, but that patient, she had been using a heavy backpack while she was hiking. So she's a pretty avid hiker. And so the ergonomics of your backpack are important. There are better backpacks that also strap. They minimize the torque arm. I don't want to go into biomechanics too much, but they minimize the torque arm and the effects on your center of gravity. So a backpack that is appropriately affixed to somebody, obviously minimize weight is number one. So with that patient, we had talked about, when she goes on these long hikes, minimizing the unnecessaries in her pack, and also making sure that it's an ergonomic fit. Chest straps help as well, so not just your 2 straps, but you can have a chest strap and an abdominal binder would be optimal.
Sure. So, I think in interest of time, to stay on time, there's just one more question, and
Okay.
I think I can just have you answer it individually through the app. Is that okay?
That's perfectly fine.
Okay. So we're going to just take a 10-minute break, and then we'll come back at 2:40. And those of you who have other small group sessions, feel free to disperse. And then we'll have Dr. Zhang next.